Assalamu alaikum dear students, welcome to Dr. Omi lectures. In our previous session we studied anemia in which red blood cell count and hematocrit is decreased. Today we are going to study the topic of polycythemia in which red blood cell count and hematocrit are increased. Polycythemia is also called as erythrocytosis, which means there is increase in red blood cell count. Just like leukocytosis is increase in WBC count, erythrocytosis is increase in red blood cell count. Let's talk about the types of polycythemia. There are two main types of polycythemia. One is relative polycythemia and the other one is absolute polycythemia. In relative polycythemia, actually the absolute count of red blood cell does not increase. It is the plasma volume which is decreased, so there is hemoconcentration. There are some conditions, for example, excessive vomiting and also diarrhea and also profuse sweating. So in all these conditions, if there is profuse sweating, excessive diarrhea, vomiting, and also use of diuretics, they can decrease the extracellular fluid volume and hence the red blood cell count may increase. And due to this hemoconcentration, the red blood cell count may increase, and this is a false kind of polycythemia which can be corrected after correcting the plasma volume level. The other type of polycythemia, which is absolute polycythemia, is also called as true polycythemia because in this case the plasma volume is not decreased. Actually, in this case the red blood cell count is increased. And in this case the polycythemia is further divided into primary and secondary polycythemia. Primary polycythemia is also called as erythemia, or this is also called as polycythemia rubra vera. In this case, there is increased production of red blood cells, just like a breast tumor has increased production of cells. So in this case, there is increase in production of red blood cells which are not under erythropoietin control. So in primary polycythemia, what happens in the bone marrow, this JAK-STAT pathway may be overactivated. Even when the erythropoietin level is normal or even decreased, this JAK-STAT pathway, which transduces the erythropoietin signal inside the cell, this is overly activated, and this increases the production of red blood cells by stimulating the steps of erythropoiesis. And this is why there is increase in red blood cell production. And by increasing red blood cell production, more red blood cells enter into our circulation. So this is why the red blood cell count and then hematocrit will increase. And because the red blood cell count is increased here, so this is why the oxygen carrying capacity may also be increased, and that can decrease the production of erythropoietin from the kidneys. We know very well that this erythropoietin hormone is produced from the proximal convoluted tubules of kidney, and also outside of the proximal convoluted tubule there are interstitial cells which are fibroblast like cells. They also produce this hormone, and cells in the peritubular capillaries, they also produce this erythropoietin hormone. So because in primary polycythemia there is increase in production of red blood cells, so the erythropoietin production by negative feedback mechanism may actually be decreased. But this decrease in erythropoietin secretion does not decrease the production of red blood cells, because this JAK-STAT pathway, this is overly activated and this is not under control of erythropoietin hormone. In case of secondary polycythemia, there is increase in production of erythropoietin hormone. In case of primary polycythemia, the erythropoietin hormone may be normal or it may be decreased. But in case of secondary polycythemia, the erythropoietin level is actually increased. And this increase in erythropoietin level in secondary polycythemia may be in response to hypoxia. And this hypoxia may be if someone is living at high altitude. For example, those who are living at an altitude of 14,000 to 17,000 feet, there is less oxygen in the environment. That low oxygen stimulates those organs which produce erythropoietin hormone. So one of those organs is kidney and the other one is liver. 90% of this erythropoietin hormone is produced from kidneys, and hence because of increased production of erythropoietin, there is stimulation of this JAK-STAT pathway, hence there is increase in the steps of erythropoiesis, so more is the red blood cell production. Because this increase in red blood cell production when someone is living at high altitude is not a disease, so that's why this is also called as physiological polycythemia. Some other conditions in which the hypoxia may occur and they can also increase the production of erythropoietin hormone and hence causing polycythemia are COPD, chronic obstructive pulmonary diseases. For example, emphysema. In this case, there is less exchange of gases in the respiratory membrane. Hence, less oxygen enters into our blood circulation, leading to hypoxia, and that stimulates our kidneys to increase production of erythropoietin, and hence bone marrow increases the red blood cell production. In case of cardiac failure, the exchange of gases in the lungs may be normal, but because there is slow flow of blood through the tissues, then the delivery of oxygen to the tissues may be decreased, and hence once again in this case there is increase in erythropoietin production. Another type of secondary polycythemia is the one in which there is ectopically increase in production of erythropoietin, not in response to hypoxia, but this may be because of some tumors. For example, a person who is having renal cell carcinoma may have increased production of erythropoietin hormone, which abnormally stimulates the bone marrow to increase red blood cell production. Another case may be hepatocellular carcinoma, because liver is the second organ after kidney which produces erythropoietin. So this tumor of the liver cells also increases the production of erythropoietin, hence increasing the stimulation of the bone marrow to increase red blood cell production. Now let's talk about the clinical features of polycythemia. If you talk about the red blood cell count, RBC count increases. Normal count of red blood cells is about 5 million per millimeter cube. But in this case, the red blood cell count can go up to 6 to 7 million per millimeter cube. And in severe cases of primary polycythemia, which is actually cancer of bone marrow, there may be too high red blood cell count. It can go up to 10 or 11 million per millimeter cube. Hematocrit in case of polycythemia is also increased. Hematocrit, which is also called as packed cell volume, normally this is about 42 to 45%. But in this case of polycythemia, this can go up to 60 to 70%, and in severe cases of primary polycythemia, it can go up to 70 to 80%. And because the red blood cell count and hematocrit have increased, so this will make our blood thicker and the blood viscosity will also increase. Can you tell me what is the normal viscosity of our blood as compared to that of water? The normal viscosity of blood is about 3 to 4 times that of water. But in this case, the viscosity of blood can go up to 10 times that of water or even more than that. This increase in viscosity will make the blood to flow slowly in the blood vessels, and in some peripheral blood vessels the risk of clot formation may even be increased. So increasing the viscosity will decrease the rate of venous return, and in this way there is tendency for the cardiac output to decrease. The red blood cell count is increased, but about the total blood volume? The total blood volume is also increased, and in severe cases of polycythemia, the blood volume can become double. If your normal blood volume is 5 liters, in cases of polycythemia, it can become up to 10 liters. In circulation physiology, you will study that when our blood volume increases, it increases mean systemic filling pressure, because the vessels will be filled more and that filling pressure will be increased. And this is one of the factors that increases your venous return. Now you can see here viscosity, when increased, it has a tendency to decrease the venous return, because by increasing the viscosity the resistance of the vessels will be increased, because blood is thicker so it will flow slowly. So that's why venous return, or the blood which is returning back to heart in 1 minute, that will be decreased. And by increasing the blood volume, because vessels are filled more, so there is more mean systemic filling pressure, there is tendency for the venous return to increase. Now what is the effect on cardiac output? Cardiac output remains almost normal. You can see here viscosity tends to decrease venous return, and increase in blood volume tends to increase venous return. So both of these two factors, they cancel the effect of each other, and this way they are balanced. So when venous return does not change much, it means the cardiac output will also not change. According to Frank Stalling mechanism, your cardiac output is directly proportional to venous return, which means that when venous return will not increase, hence the cardiac output will also not increase. What about the effect of polycythemia on our blood pressure? In about two-thirds of the people with polycythemia, their blood pressure does not increase, because blood pressure regulatory mechanisms compensate the effect of polycythemia to increase our blood pressure. So what happens? Because of increase in viscosity, there is increase in the total peripheral resistance, and this increase in the resistance increases our blood pressure. If I ask you what is the formula of blood pressure, the formula of blood pressure is equal to cardiac output into resistance. And as you have seen here, the cardiac output does not change much in case of polycythemia, because these two factors, one of them is trying to decrease venous return and the other one is trying to increase venous return. They cancel the effect of each other. So this is why when there is no increase in venous return, there is no increase in cardiac output according to Frank-Starling mechanism. And because cardiac output remains almost same, but in about one third of the people, there is tendency for this viscosity increase to increase their total peripheral resistance, and hence it will increase the blood pressure. So because in one third of the people, there is increase in the resistance to blood flow because of increase in viscosity, and this is not overcome by the blood pressure regulatory mechanism. So by increasing the resistance, and even if the cardiac output is normal, their product will increase the blood pressure. They are more likely to develop cyanosis or bluish tint of their skin because the flow of blood in the skin in the subpapillary venous plexus is slow, and because of that slow flow of blood, the tissues extract more oxygen. So when hemoglobin will be more deoxygenated, it will give a color to skin which will be having bluish or cyanotic tint. In these people with polycythemia, their hemoglobin content can go beyond 16 gram per deciliter, and in some cases it can be even more than 20 grams per deciliter. And when out of that 20 grams or even more hemoglobin per deciliter, if 5 grams or even more than that is deoxygenated, this will give a tendency for the peripheral tissues like your fingers to become cyanotic. So this is a very important MCQ point to be noted. When the deoxygenated hemoglobin in our blood is more than 5 grams per deciliter, then there is tendency for cyanosis to develop. So if someone asks you who is more likely to develop cyanosis, a person who is having anemia or a person who is having polycythemia, the answer is polycythemic person, because anemic person, let's suppose if he is having just 8 gram per deciliter hemoglobin and the polycythemic person is having 18 grams per deciliter hemoglobin, which one out of these two will have more than 5 gram per deciliter deoxygenated hemoglobin? The anemic person is very unlikely to have 5 out of 8 grams deoxygenated hemoglobin as compared to the polycythemic person, which out of 18 grams is very likely to have 5 grams per deciliter deoxygenated hemoglobin, which when present will give bluish discoloration to our skin, which is called as cyanosis. In polycythemic persons, splenomegaly may also be present, which means increased size of spleen, because spleen is the graveyard of red blood cells where old red blood cells are destroyed. So because the turnover of red blood cell is increased in this case, so that's why the spleen has become overactive, so that's why its size has increased. In persons with primary polycythemia, the other white blood cells, for example WBCs, can also be increased, and the count of platelets can also be increased, which means that along with increased production of red blood cells, they can also have increase in production of white blood cells and platelets. And this increase in platelets, this may be another reason for increase in thromboembolic conditions, which means the blood clotting may be increased due to sluggish flow of blood in the peripheral tissues, and secondly because of increase in platelets in persons having primary polycythemia. So just to summarize, polycythemia is also called as erythrocytosis, and in this case there is increase in hematocrit and red blood cell count in our blood. Relative polycythemia means when there is hemoconcentration. There is no actual increase in red blood cells, rather the plasma volume is decreased, and this can be seen in those people who are having excessive vomiting, excessive diarrhea, profuse sweating or use of diuretics. The true or absolute polycythemia is that condition which develops when there is increase in red blood cell production. It can be primary if it develops when there is cancer-like condition of the bone marrow, just like breast cancer, and there will be uncontrolled rapid production of red blood cells which is not under EPO control. It means even if the EPO level is not raised, there will be overstimulation of the intracellular signal transduction mechanism, which is JAK-STAT pathway, and that will increase the production of red blood cells to the bone marrow. So in case of primary polycythemia, the erythropoietin level is normal or even it is decreased due to negative feedback mechanism. In case of secondary polycythemia, there is increase in red blood cell production in response to increase in erythropoietin level. This can be when the erythropoietin production is increased in response to hypoxia. For example, in someone who is living at high altitude, this is called as physiological polycythemia. Those who are having poor exchange of oxygen in lungs, for example, COPD people having emphysema, a chronic bronchitis, they can also have this condition. And also the people who are having cardiac failure can have slow delivery of oxygen to the tissues, can also have secondary polycythemia. These two are pathological condition, and living at high altitude is a physiological condition. Because erythropoietin hormone is produced mainly from kidney and also from the liver cells, so the cancer of kidney and liver, which increases the production of erythropoietin hormone, can also overly stimulate our bone marrow to increase the production of red blood cells. People having polycythemia have increase in red blood cell count. Normally this is 5 million per microliter or per millimeter cube, but in this case it can go up to 6 to 7 or maybe 7 to 8 million per microliter. Their hematocrit is also increased. Normally hematocrit is about 45%, but in this case hematocrit can go up to 60 to 70, or in case of primary polycythemia this can go up to 70 to 80%. Blood becomes thicker, so its viscosity increases. The increase in viscosity of blood can be up to 10 times the viscosity of water. Normally blood viscosity is 3 to 4 times that of water, and this increase in viscosity has a tendency to decrease venous return by increasing resistance. But at the same time, the blood volume can become double in polycythemia, and by increasing blood volume there may be increase in mean systemic filling pressure. Hence it also tends to increase venous return, and both of these factors, they cancel the effect of each other. Hence the overall effect on venous return means it will not increase. So when venous return will not increase, then the cardiac output will also not increase, because Frank Starling mechanism says that if there is increase in venous return, more will be the filling of heart, more will be stretch, and more will be cardiac output. So if your venous return does not increase, then cardiac output will not increase. In most of these people with polycythemia, their blood pressure does not increase, because blood pressure regulatory mechanisms, they offset the effect of polycythemia to increase your blood pressure. But one third of the people, they have increase in blood pressure. This is because when there is increase in viscosity, this increases your total peripheral resistance. More resistance to blood flow means increase in blood pressure, because the formula of blood pressure is equal to cardiac output into resistance. So even if the cardiac output does not increase, increase in resistance will increase your blood pressure. These people, in case of primary polycythemia, along with increase in red blood cell production, can also have increase in WBC count and increase in platelet count. And this increase in platelet count can increase the blood clotting tendency. And the other reason for increase in blood clotting tendency is sluggish or slow flow of blood through the tissues. That can increase the risk of clot formation in the vessels of brain, leading to stroke, increase in the risk of clot formation in the vessels of our heart, increasing the risk of angina. And because the turnover of red blood cells is increased, so the spleen becomes reactive, its size increases, because spleen is the organ where breakdown of red blood cell takes place. And because of increase in viscosity, because blood flows slowly in the peripheral tissues, so in the subpapillary capillary axis of our skin, because blood flows slowly, so tissues extract more oxygen and more blood becomes deoxygenated. So when this deoxygenated hemoglobin becomes more than 5 grams per deciliter out of total, which may be 17, 18 or 19 or up to 20 grams per deciliter, then there is tendency for cyanosis to develop, which means the bluish tint to the peripheral tissues of our body. So this was all about the types and clinical features of polycythemia. Thank you so much for watching this video. See you next time with another video.